This briefing provides a rapid distillation of the 28 new practice-guiding consensus statements from ASGE on the endoscopic management of eosinophilic esophagitis. These represent a critical and immediate update to clinical practice.
So, why the update? Well, these statements were specifically developed to supplement the 2022 guidance. They address critical, previously ambiguous domains: pediatrics, disease assessment, and long-term monitoring. These are the areas where we needed more concrete protocols for comprehensive care. We'll structure this review across 5 domains. First, the new consensus mandates themselves. Then we'll dive into pediatric management, followed by disease assessment protocols and modern monitoring strategies. We'll wrap up with a synthesized endoscopic workflow for immediate clinical application.
Okay, let's begin with the new mandates. It's important to understand that these 28 statements are the product of a rigorous, modified Delphi process. They achieved over 80% agreement among a multidisciplinary, international group of experts. That high level of consensus is what underscores their immediate applicability and the strength of the evidence base.
So to be clear, the goal here isn't to replace the 2022 framework, but to supplement it. This guidance provides much more granular, actionable recommendations for best practice, specifically in those areas that demanded greater clarification and standardization.
All right, let's move into the first major domain: pediatric endoscopic management. The statements here address the very unique diagnostic and therapeutic challenges we face in this specific population.
Now, for children over 18 months, the consensus is clear. We need to look for a much broader range of clinical triggers for endoscopy compared to what we see in adults. Dysphagia is often not the primary complaint. Instead, practitioners must maintain a high index of suspicion for symptoms like refractory reflux, protracted vomiting, and any failure of feeding therapies. These are the key indicators.
And the rationale for this lower diagnostic threshold is very straightforward. We know that up to 80% of pediatric EoE patients have comorbid atopic disorders, so the presence of these conditions or a family history of atopy significantly elevates their risk. This mandates a high index of suspicion. Why? Because early diagnosis and intervention are absolutely critical to mitigate long-term progression to fibrostenosis and prevent the establishment of feeding aversion.
The new guidance mandates a very rigorous biopsy protocol for the initial diagnosis in children. You must obtain at least 6 esophageal specimens, and these must be from at least 2 different levels to account for the patchy nature of the infiltration. And just as important, you have to secure gastric and duodenal samples to exclude mimics in the differential diagnosis, like other EGIDs or celiac disease.
Looking at endoscopic mimics like these, candidiasis, Crohn's esophagitis, it really underscores why histologic confirmation is absolutely non-negotiable. You simply cannot diagnose EoE on visual appearance alone. Furthermore, Statement 6 now mandates the documentation of the EREF score for all pediatric procedures. This is to ensure we have an objective, longitudinal assessment of severity and treatment response.
It's crucial to understand the clear delineation here between therapeutic and monitoring modalities. Esophageal dilation is purely therapeutic. It's for symptomatic strictures, and you can perform it regardless of the underlying inflammatory activity. On the other hand, less invasive tools like unsedated transnasal endoscopy or the string test are explicitly for monitoring only. They are not validated for and should not be used for initial diagnosis.
Okay, that brings us to Domain 2, Comprehensive Disease Assessment Protocols. Now, these apply across all patient populations, moving beyond the pediatric-specific recommendations.
And here we have a foundational core principle. The initial diagnostic EGD must be performed off treatment. That means off PPIs, off topical steroids, off diet therapy. Why? Because these can obscure the findings and prevent a definitive diagnosis. A classic example, a response to an empiric PPI trial doesn't differentiate between EoE and GERD, so you have to stop it first. Statement 17 really hammers this home. Disease activity is a composite assessment. We know there's often a poor correlation between symptoms, endoscopic findings, and histology. They frequently don't line up. So you have to evaluate all 3 domains in concert. This means interpreting symptoms in the context of adaptive behaviors like food avoidance, and interpreting the peak eosinophil count alongside other histologic features and the ERFS score.
Now, here's a critical limitation that every endoscopist needs to be aware of: the low sensitivity of standard endoscopy for detecting esophageal narrowing.
We're talking about a sensitivity of only 25 to 33% for strictures of 13 to 15 millimeters when you compare it to an esophagram. That's a huge potential miss rate.
So, the clinical implication here is direct, and it should be practice-changing. You cannot rely solely on your visual assessment to rule out narrowing. Statement 21 specifically advises maintaining a high index of suspicion for strictures, especially in your adult patients where the fibrostenotic phenotype is much more prevalent.
Let's turn now to Domain 3, which lays out the evidence-based approach for long-term disease surveillance and monitoring of treatment response.
The consensus provides very specific, treatment-dependent timelines for that first endoscopic reevaluation. For diet elimination, you're looking at 6 to 8 weeks. For PPIs and topical steroids, it's 8 to 12 weeks. And for biologics like dupilumab, the interval can extend up to 24 weeks. This longer interval reflects the time needed to achieve maximal effect, which was demonstrated in the pivotal Phase 3 trials.
Now this is imperative. The biopsy protocol for monitoring is identical to the diagnostic protocol. There are no shortcuts. It's still at least 6 specimens from at least 2 levels. That remains the standard of care to accurately assess for histologic remission or recurrence, especially given the patchy nature of the inflammation. And of course, you must target any residual endoscopic abnormalities for biopsy as well.
And there are 2 final key principles for monitoring to cover. First, if you're changing therapies, a sufficient washout period is absolutely required to avoid confounding your results. Second, and this is arguably the most important point, a structured clinical and endoscopic monitoring program is now mandated. This is to prevent those gaps in care that we know directly increase the risk of progression to fibrostenosis.
So for our final section, let's synthesize these recommendations. We're going to put this all together into a practical, integrated workflow for the practicing endoscopist, translating these guidelines directly into your procedure room.
Think of the optimal EoE endoscopy as a 3-phase process. First, a careful examination. That means full insufflation, a systematic EREFS assessment, and a deliberate search for any subtle narrowing. Second, judicious dilation for any strictures you identify. And third, a rigorous biopsy technique, adhering to that rule of 6s, at least 6 samples from at least 2 different levels.
And this timeline really illustrates the core rationale underpinning this entire set of guidelines. Any delay in diagnosis, any period of untreated inflammation, any gap in monitoring, it all creates a direct pathway to progressive, time-dependent fibrostenosis. The entire goal of this structured approach is to interrupt that cascade.
So we'll conclude with a forward-looking question, one that's pulled directly from the guidelines' own research agenda. We know standard endoscopy is the gold standard for diagnosis and for therapeutic dilation. But the key clinical challenge that remains is this: what is the optimal strategy for implementing and validating less invasive monitoring tools, like UTNE or the string test, to improve long-term patient adherence, reduce the burden on patients and healthcare system, and ultimately prevent the progression to fibrostenosis? That's the next frontier.